All right. So good afternoon, everybody. Welcome. Merry Christmas. Happy Hanukkah. Season's greetings to everybody. This is we're winding down this crazy COVID year, one that I've talked to a couple of 89-year-olds and asked them how this year compared to their experience over the last 9 decades of life. And both of them, without blinking, said, this is the strangest, most disrupted year they've ever experienced. So what we're all feeling is real. And so what I'm looking to do today is to give you some updates, give you some reassurance, ease some fears, put some reality out there, and just give kind of a strategy to how we can all remain healthy until this pandemic gets behind us. I'd like to believe it was going to end on January 1st, but it's not going to end on January 1st. So the first thing I want to say is that it is real, but I really want everybody to stay balanced because we've got some extremes going on right now. Number one, everybody's mental health is getting weary. There's depression, there's just frustration, there's anger, every emotion is out there. People are getting what I'm calling COVID burnout. Their judgment is starting to lapse on choices they're making because they're so sick and tired of being locked down as we are. And that's real. We're all feeling it. So just try to remain balanced and just keep everything into perspective. So in addition to don't overly fear and recognize that we do have some therapeutics that are a lot better than we had at the beginning. Also, don't be a COVID denier. Probably people on this call are not a COVID denier, but there's a significant number of people who just want it to go away so bad. Judgment is lapsing, and I've heard some pretty irresponsible choices that people have been making and are putting others at risk. Because what we really need to do is we need to protect the vulnerable. We need to protect ourselves if we're vulnerable, number one, but we have to recognize that those that we're around might be vulnerable too, and we need to make choices based on that. And also recognize whether it's me or any expert on TV, whether they're a epidemiologist or whatever, most of what we're talking about is opinions. There are some facts and we're learning more and more, but the more I realize how far we've come and what we know now compared to when I had COVID-19 back in March is immensely more, but I still feel like the more we know, the more we don't know about this virus. Things seem to be changing. So just recognize that, and we just have to make choices and do the best that we can. Where are we as far as the virus? So I actually just checked the numbers again this morning, and November was a very bad month. We know that it was aside from the very beginning, it was the worst month that we had yet. But increasingly, both at St. Mary, where I get specific numbers, and overall CDC numbers, the number of hospitalizations and deaths seems to be coming down a little bit. Don't let your guards down because it's going to be waxing and waning. I fully expected it to be a bad fall. Most of these viruses get bad in the winter months for various reasons, and I expected it to get bad, and it did. And it's going to be cycling, and I'm speculating, hopeful that maybe come springtime, once we've got people vaccinated, once we've got more people having had the disease, the sun comes back again. I'm hoping that's where we can start to maybe put this in the rearview mirror. Fingers crossed, hope that's happened. So my best guess would be March to May, but I may be proven completely wrong. All right, so I'm going to talk first about prevention, what we can do to prevent ever getting this virus, and then what to do if you do get symptoms. So we've got a lot of people. I appreciate asking questions. A lot of them I had planned for. A couple I'm adding to what I'm going to talk about today. And so if at the end of the prevention section, if I think there's anything I missed, you got any questions, feel free to type them in. Kirsten's monitoring questions, and she's going to ask them to me at the end. In the chat section. So as far as prevention, so back in the springtime, I put out a survival guide. It's still on our website if you want to go look at it under health news, but about speculating all the different things that we might be able to do to prevent it, from supplements to all the others. Always, exercise is going to help we need to keep our immune system strong. Exercise, sleep, eating well, they're all important. I'm not going to talk about those. Those are pretty straightforward. The more we can do those, the more we're going to keep our inflammation down. And the reason you're hearing diabetes and high blood pressure being such big risk factors is not so much that they cause inflammation, but the underlying inflammation of ill health are triggering our blood sugars to go up and blood pressures to go up. So those are important to kind of just keep the lifestyles in order. I didn't mention it, but if you have available paper and pen, I'm going to give a couple specific things that you may want to jot down a couple notes over time. The couple things you can do. So it seems that the things that have risen to the top as beneficial are vitamin D and zinc. So vitamin D and zinc, that seems like everybody's agreeing that those are important ones to help out with COVID. And it's great because vitamin D, on any of you who've been having wellness evaluations, we're monitoring your vitamin D level. I encourage you to take whatever I've recommended, just take it on a daily basis. If anybody's watching this who isn't on that, and or maybe not a patient of mine, because some are on this who are not, check with your doctor, but a little vitamin D, 1,000, 2,000 is good. Many of you I have on more than that. Zinc. Zinc is one that I believe, is one of the key players in fighting off this virus. It's been interesting. We've been hearing about zinc and viruses, Zicam, whatever, these little low-dose zincs that people take when they get a cold, because zinc supposedly is good for viruses. But over the years, I've struggled with that because it hasn't been really proven to be beneficial. Well, now I think I understand why. What zinc does is zinc lodges in our cell membrane, and zinc protects viruses from attaching to our human cell membranes. And what it does is it buys some time for the immune system to wipe out virus, cold virus, other viruses, COVID-19. So what the zinc does is allows the virus not to protect, not to attach as readily. So zinc's not necessarily going to work once you get sick. And that's kind of what has been said over here. So I've never really bought into zinc when you get a cold. But what I do believe is beneficial is zinc on board to protect yourself once you do get exposed to the virus, to buy your immune system some time. So I'm starting to recommend more people take zinc. And some folks I've measured zinc levels for various reasons, most not, but generally 15 to 30 milligrams of zinc, 50 milligrams of zinc are going to be good. And through the pandemic, taking some zinc, I do think would be a wise idea. And I'm going to talk more about zinc if you actually get COVID-19, because we bump that up if that's the case. So that's the concept of zinc. And then the other one to kind of prepare ahead of time that I do believe is more important is that if I've recommended aspirin to you, take your aspirin, because we're learning that a lot of this is a lot of the complications of COVID-19 are vascular, and low-dose aspirin can help prevent some of the vascular complications. So it's not necessarily for everybody. Again, if I recommended you to take a low-dose aspirin or 2 low-dose aspirin over your wellness evaluations, please do take it. So those are kind of the basics on prevention of what you can do for yourself. Now let's talk in the topic that everybody's wondering about, the vaccine. So the COVID-19, I am thrilled that it has come so fast. Everything you've heard is true, is that this just doesn't happen without tremendous effort. So kudos to all the companies and the government for supporting this vaccine to come out as fast as it has. Few things about the vaccine. So we need to know, how well does it work? So I saw a very nice review of the Pfizer report. It's like a 92-page report. I didn't read all 92 myself, but I saw a nice review of it. And it does stimulate antibody production much better than a lot of other vaccines, including the flu vaccine. So what we're finding is that 52% of the people, this is the Pfizer, Moderna is very similar, and a lot of you ask, which vaccine should I get? Frankly, from your perspective, and I don't know anything about the third one that hasn't been approved yet, but there's not a lot of difference between the Pfizer and the Moderna vaccines. They're pretty similar. The big difference is how cold they need to be kept. So the Moderna has to be kept a lot less cold than the Pfizer, which is like crazy 80-something degrees below zero, I believe it is. So that's the big difference. So I've not seen any compelling reason to get one over the other. They're both, after the first shot, is about a 52% antibody stimulation rate. So what they're doing is it doesn't mean it's absolutely working in 95% of the people after the second shot, or it means that it's stimulating antibody protection in a really good number of people. So 52% after the first shot, and then 3 weeks later you get the second shot, and that's when it goes up to 95-ish% or so. And that's a really nice antibody response from a vaccine, not seen in most. So efficacy is very encouraging. You're going to ask the question, I didn't get any questions on this, but how confident can we be after we've had the vaccine? Well, nothing's in life is perfect, and it's not going to be perfect in everybody. So we still need to be a bit cautious on protecting ourselves, all the basic infection control measures, but we'll get further guidance, I believe, down the line once we understand the more of the effectiveness on the vaccine. But so that's the effectiveness. Safety, that's another biggie. So I mean, it's yes, this was fast-tracked, but I actually had a good conversation with a good friend of mine from my residency program, who is actually a chief of family practice at University of Michigan, and he has access to all these academic lectures. And he said he watched a lecture on the vaccine that was very encouraging. That inherently these RNA viruses inherently ought to be safer than some of the other viruses, so that the safety profile ought to be fairly good. What have we seen so far? So looking through the side effects that you're hearing about, these reactions that people are having to the vaccine. So everything I saw none of it surprised me. Almost every side effect that you saw, and it's got a higher side effect profile than some of the other vaccines. So yes, more people are going to get side effects from it, but they're all probably because we're getting a more robust response of our immune system. Most of the side effects you get from flu vaccine or this vaccine is our body's immune system mounting a response, not getting the disease, but mounting a response against the disease, giving you the side effects like body aches, tired, headache, chills, things like that. So, and most of them are within 24 to 48 hours of getting the shot. And St. Mary is even saying that if you get side effects from your shot, as long as you're not having a fever and you feel like you can still work despite getting some side effects from the shot. So that's mostly the side effect profile. The one that's not necessarily just a immune system reaction is there were a few people, not lots, but got Bell's palsy. That's a nerve reaction of one of the facial nerves where you get a facial droop on one side from it. Not very common, but that was one that they had it, and we've seen that with other vaccines too. So it's not terribly unusual, but overall, the side effect profile did not seem to be extreme. But again, it was a relatively limited number of people that were studied because we just didn't have many people leading up to this getting studied. And now it's going to be released to a lot more people, and we'll start to see anything else. So we just have to pay attention to that. So the next question is going to be who should get the vaccine? And that's all about risk benefit. So obviously in everything in medicine and life, there's going to be a risk to everything. And it's really how much benefit are you going to get from the vaccine? So the high risk people, I would get the vaccine because it's again a relatively good safety profile. It does look like it works well, and the effect of this virus can be devastating. I mean, the flu vaccine can be bad in some people. This can be worse. In the younger people, this is not as bad as the flu, but it's so the high risk people definitely. The young and the low risk people, time will tell, but that's not going to be an option for the low risk people in the near future anyway. So, I definitely encourage people to get it who would be in the high risk vulnerable category. Distribution of it, I can't say much more than you've been reading. So what I can say is that it is out there. The local hospitals are getting it. Hospital staff are beginning to get it. Not everybody yet. They're phasing it in. There's kind of a 4-phase implementation at the various hospitals of who's getting the vaccine. Obviously, the ones who are taking care of inpatients, hand-to-hand care, face-to-face patient care with people with COVID are getting it first, and then slowly but surely unveiling it for other people. Unfortunately, I've been looking, but don't see any good guidance in terms of who's going to be getting it next. I hope it's based on protecting the vulnerable. I really think that's what we ought to be doing. So I hope home health aides are going to be early on. I know first responders are going to be there early on. So I hope they're really going to be practical at giving it to people who are probably Medicare. I mean, I don't, to me, it makes sense that the Medicare population are going to be first tier to get it once it goes out to the public. And then the group of people who are taking care of the vulnerable ought to be on the list also of making sure they're protecting the vulnerable. Again, that's what this all ought to be focused on. We got to get rid of all politics, all opinion, all selfishness here. We got to protect the people who need to be most protected. So I don't know what that game plan is going to be, but I'll let you know when I hear anything. And I also have not heard anything about getting it into individual offices. I'm pretty certain that they're going to be distributed. Well, there's obviously at the hospitals are going to be one potential distribution center, probably pharmacies, I imagine, like CVS, Rite Aid, Walgreens, places like that are probably going to be opportunities to get them because they're doing other vaccines right now. And then what's going to be available at doctors' offices, it's not available to us now, and there's not a waiting list I can get on for it that I've found. And time will tell about getting it here versus elsewhere. So I unfortunately can't give you any more added information about that. So that's I think that's pretty much most of the questions that people have asked about the vaccine and what I know. So now would be a good time if you have any questions that I've not answered, type in a question about it, and I'll field that at the end. So the next is what should you do if you get sick? So first of all, keep in mind, there's a lot of viruses this time of the year. There's a lot of viruses that are not COVID-19, but obviously we need to have a very heightened index of suspicion because this virus can present in many different ways. Definitely some pattern recognition of body aches, fevers, chills, loss of taste and smell, little low-grade diarrhea are kind of the hallmarks of it. They're the most suspicious one, but it can do other things. It can cause a sore throat. I never got a sore throat. It can cause shortness of breath. I never got shortness of breath. It can do a lot of things, but you got to have a heightened index of suspicion. And testing is so easy to do now. They've improved the testing, and one of the reasons we're seeing so many cases because so many people are getting tested now. So CVS does have it available without a prescription from a physician, so you can sign up and get it done through CVS. I'm not quite sure what their turnaround time is at this point because my patients I'm sending to Lehigh Valley Genomic, which is kind of the one that St. Mary has partnered with. The reason being is that their turnaround time in the last week or so has gotten really good. We've had people getting back, most time the results are within a day at this point from this. So they get it done one day, they get tested the next day, and I think the scheduling has been within a day. So what has to happen is we have to give you a prescription and then you schedule time with them and do it. You can't just do it on your own, but obviously my patients, if a pretty low threshold for having people get tested if they've got suspicious symptoms. So that's kind of been the route. So there is as far as the testing, there is the rapid test, which is most convenient to get your results right away, and then there's the PCR test. The PCR test is more of the gold standard. We trust it a little bit more in its accuracy. I have been reading and hearing that we're getting a bit more false positives out there because there's, without getting into the science of it, they want to make sure that if they're not missing people who have COVID by having a false negative, meaning they turn out negative, but they really got the virus. That's the important one to eliminate. So in doing so, it's created a few more false positives, but we'd rather go that route than miss people who have it. But the PCR test is a little more accurate. One of the keys, though, is to how well the test is done. I actually had one patient who had on the same day both the PCR and the rapid test. The rapid test came back positive, but the PCR test came back negative, which is kind of backwards from what I was expecting. But in talking to him, the person who he did his own test on the rapid test and got a really good swab for a full 10 seconds, annoyingly, not super deep like they used to do it, but got up there far enough. When the technician did it on the PCR test, it was just for a couple seconds in one nostril. So I think it was a bad technical error on it. But in general, the PCR test is the preferred one, and now the turnaround time is pretty good. So that's the testing. So the most important thing is what to do if you get COVID-19. So there's lots to be done. Let me talk about the hospitals first. So the hospital care has gotten immensely better. I mean, they've locally and they've got a lot of interventions now at the hospitals. I'm not keeping super up on everything they're doing on that because I'm worried about the outpatient world, but they've got the treatments available now that are working much better, whether it's remdesivir or other antivirals, whether it's the Regeneron is now available, and that those are hospital care is improving. Outpatient world, that's what I care about. So I've been asked the question, if I get sick, do I go to the hospital? Do I call you? What do I do? Well, if you're vulnerable and you get sick, I want to know right away. Okay, so especially if you got symptoms that are suspicious of COVID-19, because I've walked 4 people through treatment I'm going to describe in a second that had COVID-19, who were at least a bit high risk, a couple of them quite high risk. And I've been doing a lot of reading, watching the physician blogs, the communication, the forums of the outpatient doctors that you don't hear about in the media a lot, about what works and what's a kind of a nice regimen. So I've got a regimen that I've recommended for people that seems to be working. So number one, I make sure about the vitamin D. I mean, anybody who suspect COVID, we talk about vitamin D and zinc right away and getting on your aspirin, like I talked about already. I actually bumped the zinc level up a little bit just to make sure we get as much into that cell membrane to block it as much as possible. So it depends on the person, but not sure what everybody thinks about what they've heard, but hydroxychloroquine is safe in most people and it works. Nobody's going to tell me otherwise. And I hope this doesn't get pulled off the internet because of this opinion, but I've watched it work and I've read it work. And what it does, and the reason it gets, I think, a bad name is that a lot of the studies were done on hospitalized patients. And my understanding on the way the hydroxychloroquine works is that the zinc lodges in the cell membrane, and what hydroxychloroquine does is it helps the zinc do its job better. So it's not killing anything. It's not an antiviral. It's not killing the virus. So if you can catch it early in the course and while people are at home and safe, and they don't need to be in the hospital, if you catch it early, debatable on when in the course it's not going to work as well, it has a chance of working because it helps to block the attachment of the virus to the cell membrane and let the immune system kill the virus before it can get too bad. That's how. So once a person gets bad enough to be in the hospital, it makes complete sense that it's not going to do any good. And that's where most of the testing has been done in hospitalized patients. So it doesn't surprise me in the least. It's an old medication. It's a safe medication. It's only used for 6 days. I've looked through all kinds of regimens of what people are using and come up with, I think, works best. Where there's a little bit of a loading at the beginning and you take it for 6 days, along with 10 days of a steroid. That help to control the inflammation. You know, hospitalized patients get pretty big doses of steroid because it definitely works in the hospitalized patient. That's kind of a standard of care one for them, but we incorporate it in the outpatient world too. And in the 4 people I prescribed it for, 2 of them were modestly high risk, but in talking to them, they wanted to try it, and I wasn't worried about them taking the hydroxychloroquine, and they turned around very quickly. I mean, it was impressive how quickly they turned around and started to get better. And then there were 2 people who their oxygen levels were beginning to drop. And so I do encourage everybody to get a pulse oximeter. You can get off of Amazon stores at home because it really helps in terms of monitoring you at home to know exactly when do I have to send you in the hospital. These 2 people, they weren't bad enough that needed to go to the hospital, but it was getting close. And I was getting a little edgy. I was really glad they had a pulse ox to watch it. But Their symptoms turned around relatively quickly, and the pulse ox improvement lagged behind, but they both stayed out of the hospital. And I'm pretty convinced they were on the path to going to the hospital, but turned around effectively. And I know that's only 2 people. This is not a research study. This is just as my experience, but it's my experience in watching and listening to others having similar experiences in the outpatient world with it. So the negatives you hear about hydroxychloroquine are its potential arrhythmia complications. It can do what's called prolonged a QT interval, make you more problem with arrhythmia. So I won't prescribe it to anybody who's on an antiarrhythmic, and people are on that because together they could be a problem. And in those people, we need to potentially watch their EKGs. And if somebody's got COVID, I'm not going to bring them in here. We're keeping people out of the office if we think they've got COVID or they have it. But you would need to monitor serial EKGs, and you can really only do that in the hospital setting. So I won't do it for that. But for the majority of people who don't have any significant arrhythmia problems, yeah, I believe it's a completely safe, long-standing. I mean, many people are on the dose that we use for this for months and years on end, and all they got to do is have their eyes checked periodically just to make sure the long-term effect on eye complications. So that is my, again, as I said at the beginning, this is my opinion based on the facts that I know and what I've watched. Let's see, so that's pretty much it. So if you can think of any other questions about treating, if you've got the condition, but those are the big things I got. So if you've got the condition, call me, we talk here, and if you've got a pulse ox at home, we can keep an eye and know when we need to kind of send you to the hospital versus let you stay at home safely. All right, so I'm going to stop there. And Kirsten, can you let me know if there were questions?
Hey everyone. Let's see here. Can you take too much zinc?
Can you take too much zinc? In the amounts I'm saying, you're not going to get toxic on zinc. I mean, if you're taking like 30 milligrams is kind of a nice round number. And if you've got a 50 milligram pill, or if you know you're low in zinc, some of my cognitive risk patients, low zinc is a risk factor for dementia. So I've been checking zinc on some people, and if you know that you're low on your zinc, definitely 50 milligrams of it. For the average person, 30 is kind of a nice number. They typically come in, I believe, like 5, 15, 30 milligrams in the different formulations you get over the
counter. What should you do if after receiving the vaccine you develop a fever?
Talk to me, assuming you're my patient, and we'll sort it out, because you can get a low-grade fever with anything, and we just need to sort out with this. I mean, like I was just explained that for actually check your pulse ox and then call me. And then, because that's going to be the big driver, is that you're not going to get COVID-19 from the vaccine, but I mean, yeah, Murphy's Law will have it. There's going to be somebody out there who is incubating COVID-19 at the same time they get the vaccine. But I would just say we need to talk.
Alrighty, and what O2 level would you say triggers a trip to the hospital?
There are raw numbers. That's a good question anyway, and I'm glad they asked that. That normal is, in the average person, normal is 96, 97 and above. Oh, and when you're checking your pulse ox, don't look at the first number that you get. It takes a minute or so for it to adjust and measure it. So don't look at the first oxygen that pops up on your meter. Look at about a minute into it. So average person, 96 to 100 is the normal range. Some people who may have a little emphysema or other smoking complications, it's a little bit lower. 90 to 92, it's getting a little low, not dangerously low, getting a little bit low. But it's more the trend. If it seems to be dropping rapidly, I'll tend to pull the trigger on sending you to the hospital sooner than if it's dropping slowly. I'll tolerate the couple of folks I was talking about had kind of drifted down into the upper 80s, I think like 86, 87. getting down below 85, I'm getting a little bit more nervous and thinking, but again, it's really more the trend than it is the raw number. But I mean, if you're down below 80, you're going to the hospital. 80 to 85, I'm getting close to or sending you. And 85 to 90, it kind of depends on the trend. They're kind of a nice guideline.
Alrighty. This is a easy answer. Where can you get a pulse oximeter?
I believe most drugstores you can get off Amazon. It was tough at the beginning. It seems to be, last I looked, you could get one. And which one to get? They're actually, the technology now is better than the ones I used to get 10 years ago. So they're most pretty good out there, in the range of cost, I believe, is like $30 to $50 or so.
Okay. How long after diagnosis should you keep taking zinc and aspirin? Also, should COVID positive people get the vaccine later, and when? Those are two great questions.
So the first one, how long to take zinc and aspirin? Until I tell you to stop it. So, I forgot to do, I'm gonna see if I can find it. So zinc. So I had COVID-19, and about May, June timeframe, maybe July, I looked down at my fingers and I was like, when did I whack my thumb with a hammer? I was like, no, I don't remember doing that. I realized it was a white spot. So I kind of go back to my kind of clinical diagnosis from medical school. I was like, wait a minute, what do white spots mean? I noticed 4 of my fingernails had white spots, all at about the same location on my fingernail. Well, then it dawned on me, wait a minute, that's a clinical sign of zinc deficiency. It's when I became a full-time believer in zinc. So basically what it came down to, if you map back when I would have been zinc deficient, it was right when I had COVID. And it was pretty amazing when I looked at the numbers. And sorry, I'm not going to bother showing the picture. I meant to get it out there to show everybody, but literally it's a picture of a big white spot on my thumbnail saying that I had COVID. So I got my COVID sucked the life out of my zinc, and I was transiently zinc deficient, and now they're all completely normal again. And I checked the zinc back over this, I think, September timeframe. I checked my zinc level, and it was close to normal, but still a little bit low. So basically, take the zinc until I tell you not to. Take the aspirin until I tell you not to, because we really don't know enough about all of the vascular complications. We don't know, and that's a question that I didn't address, is that how long we do, a lot of the complications of COVID-19 are vascular, and we just don't know yet what are the long-term ramifications of having COVID-19, especially if you got the pneumonia version of it. The long-term effects on the lungs or long-term effect on the vessels, but low dose aspirin in most people is low risk. So until I tell you not to. What was the second question, Kirsten? I don't remember. Kirsten, we're not.
Oh, I'm sorry.
There you go. I heard you in my ear, but I didn't hear you on the microphone. What was it?
Sorry. Should COVID positive people get the vaccine later, and when?
Good question. So that's the one I honestly struggle with. I mean, think about it. I had COVID-19. I actually just tested my antibodies this week.
That was another question we actually just got, so we can kind of do both. Have you taken an antibody test lately? And so, you just...
Yeah, so I actually did just test for antibodies this week, and I actually was thrilled, a little surprised, but thrilled. I still have some antibodies out there. So that was not expected at all, but I was happy about that. So the answer to the question is we don't know. Is the true answer to the question. Is they specifically on the vaccine guidelines, they don't address people who have had COVID, because there's a relatively minority of us who've had it. Should we get the vaccine or not? This is where I have to kind of pull on my experience in vaccines. So you heard about the measles vaccine. They were recommending doing the measles vaccine if you're not immune to it. So what you're saying is that we would do an antibody test for measles, and if you had antibodies, you didn't need the booster. And if you didn't have antibodies, you got the booster. Extrapolate that to COVID-19. Well, if you have COVID-19 antibodies, you shouldn't need the vaccine. Same thing with hepatitis B. One of the ways that we look at hepatitis B is that, do you have antibodies to hepatitis B? And if you have antibodies to hepatitis B, you're assumed to be protected to hepatitis B. And actually, in philosophizing with this on myself, back in my Air Force days, the guidelines were, you know what, if somebody is hepatitis B negative, we give them a booster. If they're still hepatitis antibody negative, we give them a second booster. And then what the guidelines were, that if they didn't convert antibodies after 2 boosters, then we just assume they're immune, because some people have a T cell immunity, but no antibodies. So you hear about the T cell immunity, you've heard whispers that probably didn't understand it. So that's a different form of immunity. That's a longer term immunity that you don't measure with antibodies. And then within the last month, there was a study coming out that suggested that those of us who had COVID-19 back in the spring, still had significant immunity, and it was addressing the whole T cell immunity issue. So the answer is that we don't know if people who have had the antibodies should get a vaccine. It's not going to hurt, but quite frankly, I think those of us who have had the antibodies ought to step aside and let the other people to get it first. And the only thing I struggle with as a healthcare provider who takes care of patients, that am I kind of obligated to do it. And quite frankly, I'm not quite sure. I would love to get feedback from what all of my patients think about that. But the bottom line is that I'm thrilled that I have antibodies right now. And as of, actually, quite frankly, as of right now, just this morning was the first time, even at St. Mary's, they opened it up to healthcare providers who are not at the hospital all the time. So, but so did I answer that question, Kirsten?
Yes, you did.
Okay.
Thanks. You answered 2 questions in one, actually. So, how is the regular flu season? I have not seen any case numbers. That's a good question.
Neither have I. Now, typically we start to see influenza around December 1st, so it's kind of early in the season for it. That's generally a January, February, March illness, but I'm fully expecting it to be a very light flu season. Number one, I think more people are getting their flu vaccines than normally do, just because they understand the value of vaccines in preventing death. And just these masks, I mean, these things are, we're doing infection control like we've never done ever by that. So that, I think cold and flu season is going to be very light this year, just because we are social distancing, we're hand washing. I mean, I don't think that the extremes that we're going to doing now are going to need to be forever. But you know what? There's something to be said during the cold and flu season to maybe not do as much handshaking, keep our hands away from our face, wash our hands more often, hand sanitizer. I mean, all these measures that are starting to become ingrained in us, even when we can stop wearing these things all the time. I think that I'm hoping that the memory doesn't fade too quickly, and that some of these infection control measures that are becoming more second nature to a lot of us become a long-term protector.
Okay. And how have outcomes changed over time for people that end up being intubated?
That's a very specific question. I can say that I did look at the CDC numbers this morning in preparation for this, and there was a big burst in the springtime. It settled down a little bit. We got another bump in the summertime. It settled down a little bit and it came down again. We got another big bump in November, not as high as the spring, but a little bit higher than it was in the summer. And that appears to be coming in both hospitalizations, deaths, the incident, the percent positives, some of the rates and the incidence of positive tests has not dropped. That's because, like I said, we're doing way more testing than ever. I know someone who's actually doing testing at LabCorp, and he says the number of tests they're doing is just never been higher than it was right now. But it appears right now that we are cycling down on this last bump. I'm not going to speculate as to why that is. But bottom line is that we're kind of getting through this bump in the road. But honestly, I think we're going to have another bump in the road sometime before the springtime comes, when I'm hoping that the increased ultraviolet light, and that's for a future talk that I give. I'm a big believer in that the sun and UV radiation kills a lot of microorganisms, and is why we tend to have the viruses start right at around September when the sun is dropping the fastest, and they go away in March when the sun is, the length of the day is increasing the most. So, but until then, we're going to have bumps in the road. We just need to be careful to ourselves and to others through the winter.
Okay, and a few more questions, and then we'll have to get off here. But do blood thinners work similarly to aspirin for these purposes?
Repeat that again. I didn't hear you.
Do blood thinners work similarly to aspirin for these purposes?
I'm presuming by that question it means Coumadin or Plavix, or I
I'm
don't
not good
know.
at pronouncing, but she gave us
Don't
the
worry.
number.
I know. Assuming that's what that was meant, that yes, that they should work as well as aspirin, because what they do is they blot the clotting mechanism, and COVID seems to accelerate the clotting mechanism.
Okay, and let's see here. If you have high blood pressure under control with meds, is it still a COVID risk factor?
Ooh, I like that question. There's a level of that question that I'm not sure the person understood. So there's a term that you've heard me say: food is medicine, exercise is medicine, medicines is drugs are a band-aid. So the drugs to lower the high blood pressure, I can give you 4 or 5 medications. Almost everybody, we're going to squash that high blood pressure, and we're basically covering up a wound with a band-aid. But the problem we've got is the inflammation of belly fat and sedentary life and oral bacteria and gut bacteria. All the things that we've talked about are the pro-inflammatory. It's the inflammatory events of life that drive the blood pressure up. So I can squash the blood pressure down with a drug, but that's not getting rid of the underlying inflammation that's driving the blood pressure up to start with. So my theory is, and again, my opinion, not proven by facts, and so little is that if you're just squashing the blood pressure down with medication, that's probably not protecting you all that much from the inflammatory event that complications from COVID-19 are. That's where getting good sleep, getting good nutrition, avoiding the unhealthy nutrition, getting good exercise, all those healthy lifestyles that we know we should do but don't really understand why, every single one of them are anti-inflammatory efforts. So I would rather have someone having their blood pressure running a little bit high, but all those lifestyles are good. And I think they're probably at lower risk if it's running a little bit high, but not terrible, than the person who has a decent blood pressure, but they're just they're covering up a lot of those underlying inflammatory processes. Great question, whoever asked that.
And then we'll finish with this question. Any specific suggestions for type 1 diabetes?
Another good question. You guys are smart people. I like you say that, because now, again, disclaimer is not proven, but again, COVID-19 complications are about inflammation. So to help people understand, type 1 diabetes usually happens in young people, sometimes in middle-aged people, a little older. I see somebody shaking their head. And but what it is when, for whatever reason, the pancreas shuts down and stops producing insulin. You don't get insulin, you die, because we need insulin to survive. So that's type 1 diabetes. Then there's type 2 diabetes. Type 2 diabetes is you've got lots of insulin, actually too much insulin. It just doesn't work as well. And in order to keep those blood sugars down, the body has to produce more and more and more insulin. So type 2 diabetics typically have really high levels of insulin, and it's an inflammatory condition. So hear that difference. So that type 1 diabetes is just a lack of insulin. Type 2 diabetes is high inflammation and lots of insulin that just doesn't work very well. And those people are increasingly seem to be at the highest risk of complications of this. So I can't say type 1 diabetics are no higher risk than the type 2 diabetics, but medical common sense tells me if they don't have if you, whoever asked the question, don't have other inflammatory conditions, I'm not terribly concerned about you compared to a lot of other people who don't have diabetes. There's a lot of inflamed people who don't have diabetes who I'd be more worried about than you who are type 1 diabetic if you've got lifestyles and don't have any other sources of inflammation. And then the last topic is there is something called an insulin dependent type 2 diabetic who has to be on insulin because their body is burning out and not producing insulin because their pancreas has been in overdrive too much. It just can't do it. You're more in the category of the type 2 diabetics because there is inflammation and insulin involved, but very different than the type 1 diabetic who need insulin. I hope I didn't spin your brains too much on that one, but that's an important one for type 1 diabetics, I think, to understand. So don't let your guard down, that especially if you're not very well controlled on your hemoglobin A1C, if you're a type 1 diabetic. So don't let your guard down. That's kind of maybe changes this discussion a little bit. If you're a type 1 diabetic who has a pretty good hemoglobin A1C, don't get panicky. You're definitely not in a low risk category, but it's on the sliding scale of worry. There's others I would be much more worried about than you.
All right. So if I missed any questions at all, feel free to email Haley and I, and we'll make sure to get you an answer to your questions. I know it's an important topic. And we recorded this, so I'm going to be downloading it later today and posting it on YouTube, and then I'm going to email out a link. So if you had family members that couldn't make it, I know I had a lot of questions about how they're going to access the recording. I'll be sending out a link, so look out for that.
And I'm going to just comment everybody that I know it's been a while since I've done one of these things, and I plan on doing these more often in 2021. I love doing it, and it's helpful. And I'm positioning everything around here that I can have more time for that. One thing I'm going to be doing is keep an eye out for it after New Year's. Is I'm going to be doing more education. There's a platform that I'm going to be working with that's outstanding about patient education, and I'm going to be shifting the patient education over to that platform that you'll hear about. It's actually going to open up education for people who can talk about topics that know way more about those topics than I do. So you'll be hearing more about that. But when you see about that, pay attention, because I'm going to shift all the patient education over to that, because I'll be able to reach more people. It'll be just as easy and keep it consistent in one platform. So, all right. Well, thank you very much for all joining us, and feel free to pass this on to friends and family members if you'd like. And you'll be getting a recording, as Kirsten said, probably later today or tomorrow. Take care, everybody, and have again a very Merry Christmas holiday season for all of you. Take care. Bye-bye.